an enchanting topic too. Death, the very pronouncement of the word brings in a lot of fear in lots of minds. If we go into the standard English dictionary, death is defined as the permanent and irreversible cessation of all inherent biological functions of a living organism. However, several of the medical dictionaries do not give this complicated a definition. The medical dictionaries prefer to define death as permanent cessation of all vital functions. From time immemorial, defining death had been very difficult. We could phrase a question this way: when does death occur? Unless we are able to define the point of time at which death occurs, defining death is also a challenge. A simple way of stating the point of time at which death occurs would be to say, death occurs when life stops. But then there is another question there. When has life ended? This point of cessation of life is the most difficult to define. And it can be more complicated when such cessation has to be defined across different organs, across different organ systems. Some time ago, about 2 decades ago, a different way of defining death was thought of. People said, death is when consciousness has stopped. But then there is also another group of people who say death is not the end of consciousness. And with concepts of collective consciousness, continuous consciousness, and so on, the definition of death becomes more and more complicated. Despite the fact that the definition of death is complicated, we all are aware of one single fact: death is inevitable. I'm reminded of the times when, long ago, when I had personally no knowledge of writing a script, not knowing how to put down even a single alphabetical letter on the paper. My parents taught me a verse of the Tirukkural. Kindly permit me to quote the Tirukkural as it is in Tamil. The verse goes like this, the couplet goes like this. நெருநல் உளன் ஒருவன் இன்று இல்லை என்னும் பெருமை படைத்து இவ்வுலகு. Freely translated, this couplet says, the significance of world or the significance of the earth is that someone who lived yesterday is no more today, and that is the significance of the world or the earth or even life for that matter. I'm also reminded of a few lines from some of the songs in some of the Tamil movies. வந்தவனை கேட்டால் சென்று விடு என்பான், சென்றவனை கேட்டால் வந்துவிடு என்பான். And there had also been a question வந்தவரெல்லாம் தங்கிவிட்டால் இங்கு வாழும் இடமேது. I'm also reminded of a statement by Kaviyarasar Kannadasan. Dr. Suresh Bhim Singh, pardon me if I'm wrong. Kannadasan obviously said in one of his writings, நான் மரணத்தை நேசிக்கிறேன், காரணம் வாழ்வை நேசிக்கிறேன். And from the philosophical perspective, death is even more complicated to define. Coming back to the scientific arena, there have been several concepts of death. One concept is what we are all tuned to and what most of us used to think of death 3 or 4 decades ago. Death due to circulation-defined death. Death due to circulation-defined death, which is called DD. If there had been a circulatory cessation, it was called death, and we always wrote death, cause of death, cardiorespiratory arrest. And then came the concept of brain death. But there again, there had been several questions. Professor A.V. Srinivasan is here, probably a little later in time. He would discuss all this. There had been brain dead women who were pronounced brain dead during their antenatal period. And with artificial support systems, it had been found that they were able to gestate fetus. So the concept of brain dead, or the concept of declaring brain death, also became questionable. In relation to brain death came the question as to what kind of electrical activity in which part of the brain, or cessation of this electrical activity in which part of the brain would decide death. This led to an enactment in the United States of America. Some parts of USA have what is called the Uniform Definition of Death Act, by which there should be irreversible cessation of electrical activity in the whole brain and not the neocortex alone. And today, there are 2 important advancements which have been noted by the scientific world. One is the development of a discipline called cryonics, by which it is meant attempts will be made to cryopreserve the whole bodies of individuals who have been declared dead. Because by certain definitions, they are not dead and they may come back. So cryonics is developing on one side. On the other side, institutions like the Resuscitation Sciences Institute at Pennsylvania have a different concept. Normally, we say some tissue becomes dead if it's deprived of oxygen for about 5 minutes. I mean, 5 or 3 or whatever, let's not bother about it. Some tissue becomes dead if it is deprived of oxygen for a particular span. So normally we say the tissue is dead because it's deprived of oxygen. But people involved in resuscitation sciences say it is not the deprivation of oxygen that causes death, but the reperfusion and the speed of reperfusion which causes death. So they say, do not reperfuse speedily. When the tissue which had been deprived of oxygen, when it gets back oxygen, It should be a slow process so that there is acclimatization and there should be slow reperfusion. And I suppose much work is being turned around at the Resuscitation Sciences Institute. So now there is so much about death that one single word can trigger more and more. There is something called assisted death. There is something called wrongful death, neocortical death, and all these terms have legal implications. Here today we have Professor Ganapathi, who is going to tell us about good death. When this topic was announced, I'm sorry to say a few eyebrows went up and asked as to what is meant by good death. And I told them that is what the entire program is about. Death with dignity is a definition that any medical dictionary gives. Death that is allowed to occur in accordance with the wishes of a patient is the standard definition for the entire phrase, death with dignity. Permit me to read the definition from the medical dictionary, Taber's Cyclopedic Medical Dictionary, the definition on good death. Death in which the rights of the individual have been respected and during which the dying person was made as comfortable as possible and was in the company of persons he or she knew and loved. This is the Medical Cyclopedic Dictionary's definition of good death. With that definition, I suppose it's time for us to listen to Professor Ganapathi, who would be talking to us about demystifying good death. Most of us would know Professor Ganapathi. He needs no introduction, at least to the medical fraternity of Tamil Nadu, which is here amidst the audience this afternoon. Professor Ganapathi is synonymous with many things, and of all those many things, one most significant thing that he is synonymous with is telemedicine. Sometimes the prefix telemedicine is added to Professor Ganapathi's name. Professor Ganapathi is here with us. Welcome, sir. And we are eager to hear what you say about good death. The floor is yours, sir.
Thank you. Can you see my slides, please?
Yes, sir. Yes.
Okay. First of all, thank you, madam. Thank you very much. I do understand that eyebrows are raised not just for good death, but for death itself. I mean, traditionally, for centuries, a physician has always been identified with saving lives. So you must be wondering, the audience must be wondering, what is death doing here? I would like to become a little personal so that I can give you the full background of why I got interested in thanatology as a study of the science of death is called. My first encounter with death, a very emotional encounter, was in 1966 when I was in the 11th standard. I got the news that my elder brother died of a road traffic accident. That minute, I decided to become a doctor. The scene shifts to 72, fourth year MBBS, Madras Medical College. Another news that my eldest brother also died in a road traffic accident. That minute, I decided to become a neurosurgeon and, as a 21-year-old, save the whole world. Over the next 50 years almost, I have encountered as a guesstimate at least 2,500 to 2,600 deaths in a very active neurosurgical career from 1975 to maybe 2015 or so. In addition, at least 60 to 70 people of my family, my extended family, neighbors, relatives, and I'm very sorry to say my own classmates, wonderful classmates of the 1968 batch of the Madras Medical College. All this has made me talk with some sort of practical experience. Again, on December 25th, 1995, Madras is the Mecca of medical care in South Asia, and it was on that day that one of my brain death patients, for the first time in South Asia, I certified brain death of a head injury patient and also put in place a system where South Asia's first multiple organ transplant was done in Chennai on December 25th, 1995. Even a few months prior to this, when the human organ transplant bill had been passed, I had written an article on how a neurosurgeon should view the critically ill head trauma patient as a potential organ donor. This, contrary to my expectations, raised a hue and cry, and most neurosurgeons in the country in 1994 were dead against it, and they thought that neurosurgeons should not be actively involved, and we would be called brain procurers or cadaver organ procurers. However, I persisted, and for the next 15 years, personally certified at least formally about 150 to 175 brain deaths, and I was actively involved in the process of multiple organ transplantation, an evangelist for brain death, so to say. In 2018, I wrote an article on brain death revisited. Some of these points Dr. Sudha has so nicely already conveyed to you. And the bottom line of this paper was that an individual could be considered legally dead in India, but alive in the United States of America. In other words, there was no global consensus as to what really constituted brain death. Is it brain stem death? Is it brain death of the neocortex, and so on? This particular article was downloaded 21,500 times and also quoted about 35 times. By sheer coincidence, just yesterday, an article which I had submitted almost a year and a half ago on good death in neurological practice has been published just a few hours ago, actually. Now, there is so much of variability in brain death determination, even in Asia. You can see there is no consensus of opinion at all. And in China, Japan, Korea, Taiwan, I'm not going to the details, the number of people who are required to confirm brain death differ from country to country. The criteria required differ. Is it clinical? Do you require an EEG? What are the tests required, etc.? And the result of all this was that at last a consensus is trying to be arrived at, and hopefully we will be able to do this soon. Sorry, I'm having some trouble with the next slide. Sorry, just give me 1 minute. I don't know why the slide is not moving. My computer is hung or something. Okay, fine. Now, the result of this was the formation of a World Brain Death Project. I'm just going to highlight one or two specific points in this. Now, it says, for example, that officially, I mean, this is the consensus of the World Brain Death Project, support should be discontinued if a hospital bed is required for a living patient and no other bed is available. Again, we now talk of death by neurologic criteria. Somatic support for death by neurologic criteria should not be done for a period greater than 48 hours, and so on and so forth. So a consensus is trying to be arrived at. Now let's look at what are the concepts in thanatology, as it is called. For thousands of years, we were talking of departure of soul from the body. When I was a medical student and a postgraduate, it was so simple to give a medical certificate at that time, the time when you could not feel your pulse, no respiration, both pupils dilated, no response to motor stimulus, and so on. cessation of breathing and circulation. Today we know that death is defined by loss of brainstem functions, and in the next few minutes I will explain this in greater detail. Contrary to what, I don't know what is being taught now, but certainly a couple of decades ago, we were taught to give a medical certificate at a particular point of time. This is absolutely not true. Death is an ongoing process, not an isolated event. In fact, death occurs even in the unborn. Even before you are born, there is today scientific data to show that even neuronal cells degenerate and die from the second trimester onwards. Apoptosis is the basis of the entire human biology. This is a programmed cell suicide, to call it, based on the telomeres in the end of the chromosomes. Again, we talk of death of the whole organism versus death of the organism as a whole. Dr. Sudha has already pointed out that different organs die at different times at different rates. It's a loss of the ability to coordinate the interfunctioning of various organs, which is conventionally taken as death, at the point of death. Difficulties in diagnosing death, I thought, was only in quaternary care hospitals where we have ventilators. The availability of several other devices now make it even more complicated. But surprisingly, this has been there for thousands of years. In fact, in a manuscript written 2000 years ago, Pliny the Elder says, so uncertain is men's judgment that they cannot determine even death itself. The Romans waited for 9 days before actually burying a person because so uncertain they were of when a person could be declared dead. In the 19th century, many coffins had health activating systems because on several occasions people were buried alive and then they found they were unable to contact those outside the coffin. So let's go to the brainstem itself. I'm not going to the technical details of what exactly the dog's eye phenomena, the absence of oculocephalic reflex, a caloric test, pupils not reacting to light, and so on. But what is more important is the fact we need to understand that even after cardiac arrest has been formally declared, the pupil reacts to pilocarpine. So when you put a miotic, the pupil constricts. How do you explain this when you say the patient is already dead? Similarly, kidneys can be used for a successful kidney transplant even as late as 30 minutes after cardiac arrest. If the kidney is taken out, it can still function effectively. For a skin graft, the viability period is 24 hours. For bones, it is as long as 48 hours. Arterial grafts, 72 hours. Valves in the heart can be used for many, many hours after cardiac arrest has been declared. We all know that nails and hair continue to grow even at the point of no return. I just wanted to show you the difficulties we had in the earlier years. This is a patient of mine in 1999, a young boy about 22 years old. The CT scan showed a massive hemorrhage. You can see with the ventricular shift in the top left. The young boy was deeply comatose, pupils dilated. The parents refused to accept the fact when we told him there's a hemorrhage inside the brain. We do not know the cause of the hemorrhage. They insisted we find out. At that time, we did not have CT angiogram, so we did a regular invasive angiogram, a carotid angiogram. And even as we were doing the angiogram, probably the boy went into brain death because the intracranial pressure was higher than the systemic arterial blood pressure. And we demonstrated, we published this as a case report on an extremely rare condition called a carotid stop, where the external carotids, the dye fills the external carotids, but not the intracranial circulation. Similarly, on the right-hand side, this was in the year 2000, the parents again insisted, and the patient was very critically ill, but even as the CT scan was going on, apparently he must have developed brain death, because this is a classical example, a very rare condition of what is called the white cerebellum, where you can see the entire brain is infarcted with the patient brain dead. The point I wish to convey is that these investigations, a CT scan cannot tell you whether the scan was done in a live patient or in a dead patient. This was a patient from Stanley Medical College, and this was again in the mid 80s or 1986 or something like that. And we did remove half the skull actually just to save his life. And after that, post-operative CT scan, which we were able to do only the next day, to our horror, we found there was a fresh bleed, a massive intracerebral bleed, and bleed on the opposite side of the brain. This was due to a condition called DIC, disseminated intravascular coagulation, which we just had no facilities to diagnose in the 1980s. Before I go into the actual point of good death, I just want to tell you what made me react like this, what made me personally get interested in this. Many of the things which I talk later, particularly the younger doctors may not agree. Now, these are the incidents which leave a firm mark on your life. Diwali Day, 1978, Government General Hospital, Institute of Neurology. I was a duty postgraduate. 9 deaths I encountered from the head injury ward, post-operative ward, fourth floor, fifth floor, sixth floor. 9 deaths which we certified from 4 p.m. till about 9 a.m. or so the next day. I so vividly remember this day because Dr. Abdul Qadir Said was a DANS, as he was called, and I was a postgraduate. And in order to make way for the beds, one of the bodies from the fifth floor was sent to the mortuary before the DANS, before the assistant could actually see. The assistant became furious, and then I almost had to go to the mortuary and get the body back. But I persuaded the assistant to go to the mortuary. He insisted on going to the mortuary and seeing for himself that the patient was truly dead. What do you do when your teacher, a former teacher of yours, a professor of surgery, a retired professor of surgery, has multiple disseminated secondaries, not only in the brain, but systemic secondaries as well? He wants everything possible to be done. He even wants proton treatment. How do I tell a very elderly professor, sir, your days are numbered, it's a question of weeks? What is the point in doing all this? So these are the practical problems we have in life. Again, I distinctly recollect a wedding reception, and during the wedding reception, the groom had a massive hemorrhage, probably burst of an aneurysm, and it was such a tremendous job to tell the just married wife that, look, your husband is unlikely to recover. Is it worthwhile putting him on a ventilator? Why do we have to go through all this, etc.? Again, an aunt of mine, 92 years old, she developed a bilateral stroke, left hemiplegia plus right hemiplegia, fell down, trivial fall, had a fracture of the hip, unconscious for 2 months. My cousins, age 72 and 68 years old. So we decided, we took her away from the hospital, kept her at home. 2 months or over, she continued to be unconscious. Imagine the plight of looking after a 92-year-old woman on a rice tube, on a catheter. Of course, we knew enough, all of us were educated, we knew enough, so we took her away from the hospital, brought her home. But then a stage came. And so I took the decision, even though it may not have been legally appropriate at that time. I said, look, we have done our best, our conscience is clear, you remove the rice tube. And I said she should stop breathing in a couple of hours. To our horror, she continued to survive for 72 hours, even after the rice tube was removed and no feeding was done. These are the practical problems. Now, as I said, I don't know whether students and postgraduates today are taught about palliative medicine, but we learned all this. We learned all this only after seeing hundreds of patients. Again, I had to keep a father alive in a deeply comatose stage, purely so that the daughter's marriage would be completed. At least the family begged me. They said, sir, somehow or the other, see that he continues to breathe for at least 96 hours more. Otherwise, the daughter's life will be ruined completely. Again, Dr. Sudha had just mentioned about I had a personal experience of one lady, a terminally ill pregnant woman whom we kept her alive for just 2 weeks, of course, 2 weeks, and then it resulted in a cesarean operation. We were able to save the child, saving the unborn. So these are the practical problems which you have in the real world. Now I come to the main part of my talk, having given the introduction on what is good death. Before that, of course, I have to confess that your attitude to death is a function of the whiteness or darkness of your hair. Having completed the biblical 70 and 10 years, possibly my concept of life and death is a little different now than what it was 2 decades ago. I understand that the destination cannot be changed, but decisions can still be made about what the journey should be like. And it needs you to be aware and take charge. I somehow find, as I said, maybe I'm wrong, but I somehow find that most doctors think the only raison d'etre, the reason for their existence, is to save lives. They often forget that death is an inherent part of your life. I strongly believe that death is a grand finale. The death is a part of life. You cannot dissociate death from life. And Justice Chandrachud, Supreme Court judge, when he passed a historic verdict in India in September 2018, where he said the right to die with dignity is a constitutional right, he made the same observation that death is an inherent part of life. So please, doctors who think that their existence, I mean, a couple of weeks ago, I heard, I listened to the seminar on mucormycosis. It was fantastic to see the incredible surgery being done. Maybe both eyes exenterated. Yes, maybe the family wanted it, but at what cost? How often do we spend our time taking into account what the patient wants, what the family wants? This is okay for proper palliative medicine, where you know a cancer patient, a terminally ill patient, there are weeks, months before you know what is going to happen. But in neurosurgery, the life is totally different. An 18-year-old boy meets with a road traffic accident, a hyper acute emergency. How do you tell the parents? How do you discuss with them what is the difference between a good death and a bad death? Again, a person with a stroke, an intracerebral hemorrhage, a glioblastoma, malignant tumor, where we're talking of a few weeks, etc. So this is what I very strongly feel, that a doctor's job profile, if you want to say, is not just being familiar with 2025 state-of-the-art, future-ready technology. Most neurosurgeons get a kick out of doing intraoperative MRI. They're able to remove tumors from the medulla and the midbrain. Fantastic surgery. They're superb technicians. They're wonderful carpenters, electricians, and what have you. How many of us take the time to talk to the family, find out the socio-economic status of the family? What is it that the family wants? What is it that a particular patient would have wanted had he been alive? And this has to happen much earlier, not wait till the patient is admitted in the ICU. Dr. Abdul Kalam, former president of India, was the rarest of the rare. Less than 10% of people above the age of 50 die suddenly. And the older you become, even less it is. An 80-year-old, a 90-year-old, a 75-year-old, by statistics, he knows, she knows, at least a few weeks, at least a few months, that the end is imminent. It is extremely rare for somebody to just stop breathing and just leave the world. That is only the rarest of the rare. There were two articles for leaders, actually editorials published in The Economist, and I was very, very sad to read this. On the one hand, the medical care in India is better than the best. I can talk about my specialty. 99% of any neurosurgical treatment which can be done anywhere in the world today can be done somewhere in India, maybe at 20% of the cost or 30% of the cost. We are absolutely second to none. Not only neurosurgery, but you take in any medical or surgical specialties. Unfortunately, as recently as 2015, when the quality of death index was confirmed, a very objective scientific method of giving weightage to various criteria and giving ranks, India ranked 67 out of 80 countries where this study was done. Let's stop death. What makes India one of the worst places to die in? Yes, we may have problems in providing hospital care to everybody, in reducing the doctor-patient relationship, in beds, in nurses, for paramedical personnel and whatnot. But why is it that India continues to be one of the worst places to die in? I strongly feel that this is because palliative medicine as a specialty should be a part of your curriculum for every medical student, for every doctor. We all the time we talk about saving lives, we talk about quality of life. At a personal level, I was probably obsessed with quality of life. I was a very conservative surgeon, and I would not even offer surgery if I felt that there was a risk of introducing a new problem with the quality of life. But today, after in a semi-retired stage, with the quietude of requirement, as you call it, when I have more time to introspect, I wonder whether did I spend all my time in the ICU looking at ventilator settings, repeating electrolytes, getting multiple specialist opinion from a medico-legal point of view, doing that, doing this, tracheostomy, even of course, when I was there, ECMO had not yet come, but today's doctors talk about ECMO, etc., etc. Should I not have spent at least 10 minutes? And I don't think any of us are so super busy that we cannot spend 600 seconds in a day talking with the family, explaining to the family, trying to find out what is it that this person would have required, would have wanted, finding about his life, etc. Again, we don't bother about, I mean, I won't say we don't bother, but maybe we should spend more time about financial aspects, etc. Patients dying in a hospital ward, particularly in the ICU, most often receive aggressive care. I'm not for a moment against ICUs, but I very strongly believe that we need to take into account what the patient wants. It is not an option. When we discuss with the family the management options between stenting, between different types of surgery, etc., do we spend time asking them what they want? I think this is important. We need to discuss with them. The more the management options today, weightage to patient desires need to be given. Clinical practice requires judgment, wisdom, and compassion, not just technical mastery of future-ready technology. How many of us know that the World Health Organization has given a separate classification? I don't remember the exact terminology, but bereaved caregivers today, they have shown that they develop mental health problems much more than the general population. This is not only for dementia, not only for Parkinsonism, but also in anybody who has been in ICU for a long time. Again, the VC has already introduced the concept and definition of good death. The single most important pain is pain. There are some things which we cannot prevent. I think it's a crime not to give somebody morphine. I mean, to hell with whether he's going to get addicted to morphine or not when the patient's life is at stake. I think it is a crime if somebody dies in pain. And again, it's only very recently, a few years ago, that today morphine is available, but even now, morphine is not as freely available as it should be. There should be no distress, no suffering, not only for the patient, but for the family and the caregivers. Death should be consistent with clinical, cultural, and ethical standards. Again, an erroneous concept is the fact that when end of life is imminent, with consent, aggressive therapies, medications, and interventions can be stopped. But do not stop care. Do not make the mistake of equating care to IV fluids. Care is not just putting him on a ventilator, on a very sophisticated ventilator. Care is something human. Care is the interaction between the doctor, the nurse, and the resident with the family. Care should never, ever be withdrawn, even if intervention is withdrawn. The process of death should sustain a belief that life is still worth living and there should be some hope. Excessive or futile treatment should not be used just to prolong life. Looking back over 42 years of active neurosurgical practice, I'm sure that on several occasions I did the mistake and I just continued the treatment just to prolong life without even thinking of the quality of good death. Of course, very few of us luckily are exposed to what is called bad death. Maybe in Afghanistan right now, this is what is happening. In bad death, there is violence, severe pain, torture, dying alone, being kept alive against one's wishes. Again, to become personal, I got a call when I was outside the country that my father was admitted in the ICU. I was in Germany. I took the next flight from the airport. I went straight to the ICU. My father was 94 years old at that time, and I brought him home. The consultant and the younger doctors were very upset with me. They said, "Sir, tracheostomy, ventilator, there's a good chance," etc. I said, "I know my father. Thank you very much. I take the decision." I brought him home. He surprisingly, he improved. 2 weeks he was with us, and then he left in his own bed, in his own room, in his house, surrounded by every one of us. I cannot think of a better death. So this is something, you see, you need to draw the line. Yes, I'm not for a moment saying aggressive treatment should not be done, but you need to draw the line and give up. Understand that you are not God, that you cannot save everyone's life. Assisted dying has already been referred to. Again, India has just come 9th March 2018. A 5-judge bench of the Supreme Court recognized living wills made by terminally ill patients and held the right to die with dignity is a fundamental right. Unfortunately, the Supreme Court did not give directives. Some of us in a 1968 batch of MMC, we did try. I went to an advocate, we went to a magistrate, we even went to a high court judge, but then the high court judge himself said, this health is a state subject. Unless the government of Tamil Nadu takes the initiative and gives us the process of how to register a living will, even though there is a Supreme Court of India directive, it cannot. And he suggested do alternatively come to us with a PIL. An advocate wanted 5 lakhs for a PIL. So this is the tragedy. The Supreme Court has said, yes, living wills can be made, but the procedural lapses, the process of doing it. And madam, I would be extremely thankful to you. I think all the doctors, particularly senior citizens like us, we would be extremely grateful to you if you could please help us introduce this. And Tamil Nadu should be the first state in the country to make living wills actually happen. Dying with dignity. It's your life. It's your choice. Grief counseling in India has medical legal issues. How many of us know? Many of us know. We don't follow it. Luckily, there has been no test case in court. I myself have discharged so many patients at request against medical advice. But from a strictly legal point of view, even brain death can be evaluated. Formal testing, including testing for apnea, including testing for PCO2, PO2, etc., can only be done if they're willing for organ donation. You cannot do as the law as it stands today, excepting the government of Kerala, which introduced this a few months ago. You cannot do a formal brain death test purely for the purpose of stopping treatment. Dying is a process that can be influenced. We are all aware of primum non nocere, but then this is about the physical body. Do no harm rarely extends to emotional or economic domains. End of life discussions is very difficult, but we need to do it. End of life discussion should be initiated within days or even hours of admission with individuals who are in an excellent health when this was totally not anticipated at all. With standards of life increasing, with longevity increasing, are we postponing death? Are we do we still have a good quality of life, or are we postponing death? By postponing death, are we unconsciously not increasing suffering? The wishes of the family must take precedence over using tomorrow's cutting edge technology. This was a report in The Economist in 2011. 10 years later, I presume the percentage would be much more. I myself belong to this group. My wife and I stay alone. So 6% of senior citizens in India in 2011 stay alone. As the years go by, this percentage is going to become more and more. I presume it is at least 10% or 12% now, and maybe in the next 10 years, it will become even more. What are our major problems? Our major problems is a refusal to talk about death. And I would once again like to thank the university for even allowing this topic to be spoken of. Most people just do not, they think it's ghoulish, macabre, it's inappropriate. Yeah, and everybody's talking about life. What do you mean by talking about death? So this is a major problem we have. The legal system is worried about misuse and therefore has put in so many ifs and buts that it's going to be extremely difficult even for the normal person to execute, to give an advance directive. We have poor access to systems that control suffering at the end. We just don't have professionals who can address total pain. Again, loss of decision-making capacity. At the end of the day, it is my life, and I alone decide on what the type of my death is going to be. When I'm in an ICU, I may not be in a position. That is why in most Western countries, they decide on what they want to do. I have made it very clear. At a personal level, I have told my family, my friends, everybody, I have told them exactly, I don't want a tracheostomy, I don't want a ventilator, I don't want to be in an ICU, etc., etc. So this is something which needs to be discussed with everybody. Last year, at the peak of the pandemic, Dr. Pratap Reddy, all described as the architect of modern hospital healthcare, after all, he heads the Apollo group of hospitals. The board of directors of Apollo hospitals made a conscious decision that from building more and more new hospitals, from mergers and acquisitions and taking over sick hospitals, etc., etc., their whole approach is going to be different. They are more interested now in putting 100, 200, 300 satellite care units which will be linked to the existing main hospitals. And I foresee, and thank you, madam, for emphasizing that I've been very active on telemedicine. Telemedicine has now become an integral part of my life. And I am sure that in my lifetime, thanks to the COVID, I am sure that I foresee that in the next 10 years, the hospital will only be a place for procedures, and most of the treatment will be done virtually. Treatment outside hospitals is going to be the future of healthcare. This is a statement which a very well-known, important person has made last year. 90% of all people want to die at home. I'm included in that 90%. But in the reality, 75% die in hospital. Just look at this, a few paper cuttings. 96-year-old seeks mercy killing. Just put yourself in the place of a 96-year-old woman with 3 daughters. She seeks a collector's permission. There is nobody to look after her. She has no money. Again, is it possible to pass away comfortably at home? Yes, it is. Hospice palliative care at home is the norm in rural Kerala. Mumbai couple wants euthanasia permission from the president. Of course, at the other extreme, a past president of the United States of America are very clear, and both Bush Sr. as well as the second Bush, both of them died at home in the comfort of their families. Death cafes. These are all in most of the European countries have these death cafes where meetings are held over tea and cakes. At no point in the history have people lived as well as we are living today. Therefore, this is the time you need to discuss quality of death. Death over dinner. This is a movement. Groups of friends host dinner parties just to discuss where the agenda is how are we going to die, how do you want to die, and so on and so forth. How we want to die is what a website says, represents the most important and costly conversation America is not having. End of life conversations. And this is what you do. Of course, you use modern technology. This is augmented virtual reality. So this very elderly woman is given an immersion experience, as you call it. She literally goes and sees. When she's in a good frame of mind, she says, this is what ECMO means. This is how you'll be connected to a life support system. This is what can happen, that can happen, this can happen, etc. You decide what you want in your life. Shakespeare, even though he was not aware of the term good death, he expressed it beautifully when he said, oh, let him pass, he hates him that would upon the rack of this tough world stretch him out longer. Let go. How to plan for a good death. When is enough enough? There is so much of voluminous literature available in the Western world. This is a fantastic movie, and I think this title says it all. Death saved my life. What a beautiful choice of words, and I totally agree with it. I do not want a condition to occur where I want my life to be saved by stopping treatment. I think this is the bottom line. Death saved my life. Dying with dignity is possible. A good death is better than a bad life. Kerala doctors can take brain dead patients off life support. Family nod is not needed. The legislature has passed it, so the doctors and with, of course, the appropriate inbuilt safety measures can do this. Of course, Tamil Nadu, I hope there is some expert in palliative medicine who will be able to talk better than me. I understand Tamil Nadu ranks number 2 or number 3, but Kerala is certainly the best so far as palliative medicine is concerned. Every district, I'm told, has got a full-fledged palliative medicine. This is one of my favorite slides which a friend of mine gave me 9 years ago. This was a preemie, as you call it, I think, a preterm baby. And this was how this baby was looked after between 2010, a neonatal intensive care unit. Okay, maybe a newborn baby, maybe it is worthwhile spending $100,000 a day. But are you really justified? At the end of the day, it is society which is spending the money. Do I want this when I am 80 or 85? No, certainly not. At least I must be given the choice. This is a paper from MIT, Massachusetts Institute of Technology, one of the world's leading institutions, biotechnology, DNA testing. They predict that within the next 10 years, the research on telomeres has become so sophisticated that it may be possible to know within 1 year plus minus when you're going to die based on a detailed genetic study. Advanced care planning. Now, this again needs to be implemented. We need to include this in a curriculum. We need to sensitize medical students, postgraduates, doctors, etc. How do you expect the poor patient to know about this? The initiative must come from the treating doctor. The treating doctor must discuss. And I think that we as medical doctors, none of us are immortal. It's a question of time. Maybe next year, maybe 10 years from now, maybe 25 years from now. But I think we should do advanced care planning and we should start how all this is. Life-saving treatments, you have the right to refuse any or all of them, but then all this should be done before you fall ill, not after you fall ill. COVID has changed our entire perspectives on life and death, including my own perspective. I have lost classmates, I have lost friends, I have lost neighbors. And the most horrible thing is because some of them died of a COVID death, even the last journey, we were not able to take the last journey. I'm glad that the Indian Council of Medical Research has now formalized the consensus guidelines on do not attempt resuscitation. Things are a little better now, but last year at the height of the pandemic, it was terrible to see where even cremation was so difficult. The new ways to grieve. Imagine grieving over a Zoom chat, typing comments in the chat section, posting photos online, paying respects to the departed through a video conferencing system. Hospital policy precludes loved ones in the ICU, and so on and so forth. So this is what is going to happen. I would like to end branching into a new area, not really a new area, an area what I would like to term neurophilosophy. The Bhagavad Gita chapter 2 says very clearly, the Atman is neither born nor does it die. Unborn, eternal, constant and ancient, the Atman does not die when the physical body is extinguished. And Yamadharma, as Yudhishthira said, what is the greatest wonder? When Yudhishthira was asked, he said, and I'm quoting that English translation, unfortunately I don't know Sanskrit, and Sanskrit is beautiful. Day after day, countless creatures reach Yamadharma's abode, yet those that remain behind believe themselves to be immortal. What can be more extraordinary than this? Benjamin Franklin said there are only two certainties in life, paying taxes and death. But then many of us are still not willing to understand it. Sadhguru remarked this very nicely when he said, the worst that happened to oneself if one has to live forever. The final hour when we cease to exist does not itself bring death. It merely of itself completes the death process. We reach death at a particular moment, but we have been a long time on the way. It matters not how a man dies, but how he lives. The act of dying is not of importance. It lasts so short a time, and so on and so on. But all the philosophers have mentioned this very clearly. Again, paying homage to Dr. Abdul Kalam, I love this poem which he wrote. One day we all will depart on a journey free of cost. Don't worry about the seat reservation. It is confirmed. The flight is always on time. Our good deeds will be our luggage. Humanity will be our passport. Love will be our visa. Make sure we do our best to travel to heaven in business class. I would say first class. It is up to us to decide whether we are going to travel our last journey by business class or by first class. Again, death complements life. Death is a part of life. Do not consider death as separate from life. I could go on and on, but I think I will stop here. So, what is my take home message? The take home message: accept the fact that we are not immortal. You and you alone have the right to decide how you want to make your final journey. Of course, I cannot decide from where my journey is going to take place, when it is going to take place, with whom is it going to take place, how is it going to take place, may not be, but I have the right to decide how I want the actual journey to be done. It is not ghoulish to discuss and record advanced medical directives while healthy. And I would, if this talk has sensitized people, and if even a few of you decide that it is worthwhile to take advanced medical directives, and more important, that Tamil Nadu becomes the first state to actually implement the Supreme Court judgment of 2018, I think the university would have done a great job. Thank you, madam. Thank you once again, and thank all of you for giving me this opportunity.
Thank you very much, sir. Thank you very much for a very wonderful,
Hello.
I call it lecture or a brainstorming session. I think everyone enjoyed it. Sir, can you hear me?
Hello.
Sir? Sir, we can hear you. I think he would have to.
Hello.
Sir, can you hear me, sir? Sir, can you hear me? I can listen. I cannot speak. Sir, can you hear me, sir?
Hello.
I think we are still here. We are still seeing his screen only. He would have to close the screen. I think he's closing. Yes, Dr. Beam Singh, you're able to.
Hello.
Sir, sir, everybody else can hear me, sir. Can you hear me, sir? You will have to tell him, Pushkala.
I finished my talk.
Yes, sir. Yes, you have finished your talk, and I'm talking, I'm responding, but then I think you're not able to hear me. Everybody else is able to hear. I think Dr. Pushkala, please tell him, please tell Professor that.
Hello. I completed my talk. What happened? No, everyone, listen, 45 minutes. Oh, okay. Now you saw my slides, yeah?
Yes.
Sir. Okay, I got scared. I thought, okay. Now, sorry. What do you want me to do? Cancel my slide share. Okay.
He's doing it.
Cancel போடுங்க share. Hello. I'm assuming my talk was good, yeah?
Yes, sir. It was very clear and
Everybody is responding.
Okay. Slides correct. Okay. Okay. Suddenly I discovered that nothing was there.
Lokesh, can I talk? Yeah. Sir, Professor Ganapathi, sir.
Yeah.
இப்ப கேக்குறதா சார்? கணபதி சார், நான் சொல்றது கேக்குறதா சார்? இல்ல, அவருக்கு நான் பேசுறது மட்டும் கேட்கல. I don't know what is happening. அவரோட ஆடியோல ஏதோ
Sir, Professor Ganapathi sir, can you hear us, sir?
Everybody is saying, everybody is hearing each other, right?
No, I think he has pressed
Thank
some,
you very much. I think Pushkala, please tell Professor Ganapathi sir, we are commencing with the interaction. Sir, the rest of you in the audience, I think that was a wonderful lecture that we had from Professor Ganapathi. Without wasting much time, we'll inform Professor Ganapathi through another source that we heard him, and we'll get him, or we'll check the technical snag and get it rectified. Meanwhile, I have Professor A.V. Srinivasan and Professor Subhash here with me at the university. Before I invite questions from the audience, if there are any, I would request Professor A.V. Srinivasan to give his comments on the concept of good death as elucidated by Professor Ganapathi, and also your own remarks on the various definitions for death, sir. Yes, sir. Please, sir, you can come here, sir. He is not closed his. He's not able to close his application. He's still not closed his application. You can, sir. You can.
Hello. Hello.
No, you carry on, sir. You carry on.
ஷேர் பிரஸ் பண்ணேன். ஷேர்ல வந்து சரி. ஓகே. ஓகே. சரி.
You continue, sir. Please carry on, sir.
Three facets of lectures of yours. First thing, people should be allowed to die. It's a very interesting concept that if you look at philosophy, then it DC itself, I think Zeno, he called it as a zero concept. The zero concept, you take it, when I am alive, I am not seeing it. When I die, no longer exists. So for this purpose, why we say that this is a zero paradox, he calls it. And we are discussing on a point in which do we have a free will? This is a very interesting concept on the neurophysiological side, where Liebert gave a nice experiment. Our brain activity starts 1000 milliseconds before, and 700 milliseconds later, you get a feeling, and 300 milliseconds later, you have to action. In which case, the brain activity clearly precedes chronic brain failure. So coming back to that definition, this requires a very in-depth. Vice Chancellor gave the definition, but what is a real death when it comes into that? Very difficult to define the death because it's very difficult to define awareness at the present. I'm aware of myself and the environment is the first characteristic of service. It is beyond our thought. Thought is the limitation of our science because we have done only the spatial sequence of thought. We have never done the temporal sequence of thought. Where does it arise from? In which case, the awareness is totally beyond our control. And hence, at the ancient people gave the definition of good death and and then in the engage people time. These are the only two bad deaths. Let's tell them around good death. There is no such thing as when we want to discuss it. When a child is going to die, that is very difficult to swallow that. And when the normal action due to the disease is due to some accident, that is a bad death. All the other things are good deaths only, whether it is by the disease or by the disorder or any sickness. Only thing is, when we have to discuss the process of the death, that itself is a disease because you are not sure of that and you don't know what is death. In the science, we always believe in experiential opinion that is faith. And at the present point of time, we are not able to define the exact point at which the awareness do not know. And this awareness, when it goes, we call it as a coma or coma-like states. Whereas the death is the distance of the awareness itself. Hence, it started thinking. I always call it science. Ultimately, particles are left to come and go with this. Biology of the matter and only the energy. The death is not acts on the circulation, it acts on the. And it's surprisingly noted that even after the cessation of the circulation and as well as activity of the lung and then the cardiac arrest, the brain activity goes 15 minutes. People have now shown that there is an increased electrical disturbance by some of them have become cancer cells, and it is very surprising. Now, why I am giving all this? There are two schools of thought. One, the physician's role is very clear. Sometimes to really often that process he comforts the patient. But to give the direction to the patient, to give the depth, the classifying family, is not under the control. Very difficult to give that handled by us. So there is a strong group. Doctors should not be done by the spirit. Other people there, they really thought of this. Once the doctor's role is the fix in the hand of the living, telling the people. Talk about telling them how well to do. This is not a but some of them can be made to the hospital. Then they can make the majority of anybody's reason why the legal expert about the doctor's people. There are so many other things. Taking the decision of not giving both Bombay and Delhi people are volume of addition is money people as non health is a state subject. Hence, the monetary aspect in America when a person is getting given disease. I think that there are beautiful articles which have come, and I always call it PQRSC for mnemonics and DCL. Once the alphabetical order, where can just say the most important thing is in between for physician. The B stands for basic, H stands for healthcare professional. All of them, and if you are fortunate enough to have all the three, thank you very much.
Thank you, sir. Thank you. We have Professor Rajendran here. Sir, I think slowly everybody kind of said, including Professor Avius, it is the physician's role to comfort and cure. And then there's so much of discussion about discomfort and curing. What is your viewpoint, sir? Professor Rajendran, for your viewpoint, please. Sir, CR, sir. CR, sir. Sir, CR, sir. நீங்க மியூட்ல இருக்கீங்களா? Before Professor CR comes in, Dr. Sabha is there. Dr. Sabha. Dr. Sabha, you're also on mute.
Hello.
Yes,
Good afternoon,
yes,
madam.
sir. Yes, sir.
I think, and we were so lucky to have clinicians and experts and also philosophers as our teachers, madam. I think it took us back to the student days, and many times we used to think whether we practice something probably not rated as a profitable business in our career.
Hello.
But
Sir, CR, sir, one few minutes. Unga line varlangiradhunala Sabha is just talking. So let Sabha finish, sir. Then Professor CR.
no, I'll follow SARS, madam. I will wait, madam. No problem.
Yes,
First,
sir, teachers first. Teachers first.
Yes,
and
yes,
we are happy. Professor
yes.
CR is with us, sir. CR, sir, your opinion, please, sir. No, he asked someone, join பண்ணிட்டீங்களா கரெக்டா வருதான்னு கேட்டாரு. அப்புறம் ஹலோன்னாரு.
அப்புறம் அன்மியூட் பண்ணிட்டார் மேடம் திரும்ப.
இன்னும் மியூட்ல தான் இருக்காரு. இல்ல, he asked someone else to check that. Sabha sir, நீங்க கண்டினியூ பண்ணுங்க. When our joins we can.
Okay, ma'am. And Dr. Ganapathi sir, and he started the telemedicine in Anna University and Shankar Netroy, madam. I have attended his telemedicine program. So I think very impressive guidance for us, madam. Because we are small, we cannot say it's an impressive lecture, but a very good impressive guidance for us, madam. And thanks for arranging everything.
Thank you, sir. Thank you. Dr. Ranjit from Nagarkoil.
Yes, Dr. Sudha.
Yes, see, you're from the field. So
Yes.
what is your viewpoint and what is your opinion? Yeah, please, your opinion and your viewpoint, because you're from the field. You know, you're right in the field there.
Yes, actually, I don't have much to say, but I tell you, like, this particular talk of Dr. Ganapathi, Professor Ganapathi, was honestly enlightening. You know, like, it's something which has opened out a lot of things for us to think about and also that be inspired on. So, sir, we have learned a lot from you. And of course, you know, like, well, I must also say, like, things are all different, you know, in different areas and different prospects and different kind of specialities wherever we are exposed to. So I guess unless, you know, like it comes in as an accepted consensus, we probably have to wait or develop our own things and perform accordingly. Is that right, sir?
Yes, correct.
Yes, Ranjit, you're right. Unless, you know, there is a kind of a consensus in many things when you know, these are emotion charged areas, and anything concerned with emotions and human feelings, probably the borderline between this way and that way is very, very narrow. And
Yes.
there are lots of gray areas which need to be sorted out. Probably each one would be right from their own perspective. So thanks very much for that. And Dr. Ravindra Mohan, sir. Dr. Ravindra Mohan. Raghunandanan Sendrakara.
Yes, ma'am. Yes,
Would
ma'am.
you like to say anything, sir?
Yes, ma'am. Very wonderful talk, wherein it brings us, all of us, human beings, ourselves personally, family, patients, all on one platform. Actually, this is the great, as they say, death is the great unifier. It brings everyone on the same plane. On a personal note, I lost my father and mother in the last 1 year. So that was one reason why I wanted to see what a good death is. Both of them had pain-free deaths, absolutely free of pain. And so that makes us, because there's nothing more you can do for them. So if the death has been free of pain and sudden, both of them had sudden deaths. So as Professor Ganapathi said, it's uncommon for elderly people. My father was 85, my mother was 79. Both of them had sudden, painless deaths. So possibly it's on a human level. As a son,
Hello.
I feel that
Hello.
there's something to be happy about in retrospect. So that's something I really gained on a personal note. Of course, there's so much of knowledge and so many things to pick up and take on. Thank you, sir, for the good chat.
Thank you, sir. Thank you. Professor CR is joining in. CR, sir?
Hello.
Yes, sir. We're all
Yes,
waiting
madam.
for
As
your
I
opinion, sir.
was waiting. One
Sir,
of
we
my
are all
patients
waiting for
just
your
waiting
opinion,
outside
sir.
On what, madam? Because I was attending with an emergency.
Oh, okay, okay.
Hello.
Sir, you heard Professor Ganapathi,
No,
sir?
no. Yes, very much. I was hearing it.
Yes, sir. Sir, your remarks or your opinion?
On good death.
Yes, sir.
No,
Yes, sir. இல்ல, அங்க
that is a
audio
problem.
network problem அங்க.
Hello.
Yes, sir.
Hello. There's a network problem, madam. I'm not able to get a connection.
Yes, sir. We understand, sir. We understand, sir. We'll wait for your connectivity level to improve. Is Dr. Raghunandanan inside? Dr. Raghunandanan, please. Raghu, sir?
Hello.
Hello, sir. Hello,
Am I audible?
Sir, you're audible, sir. Sir, probably you can switch off your video and then talk. Maybe the connectivity will be better. Sir, பேசுங்க sir.
Hello.
Yes, sir. We can hear you. பேசுங்க sir.
இப்ப கேக்குதா? Is it am I audible
கேக்குது
now?
sir. பேசுங்க sir.
Yes, my mighty senior Professor Ganapathi has talked in detail about what is good health, good death, sorry. As he rightly told, death is a part of our life. Nobody can deny. But what we are all, most of our patients are expecting is, எனக்கு நல்ல சாவு வரணும், சாவு நல்லா இருக்கணும்னு எதிர்பார்க்கிறாங்க. What I am practicing is at least 10% of what Professor Ganapathi is practicing. What is the problem today? As he has rightly put it, in any hospital, especially in a well-equipped hospitals, there is is a go on trying water they have to save life, finally hand over totally kind of useless or always depending upon somebody's support and help for the rest of their life. So the time has come to talk about good health, good death, good life. I can't say good birth. That is also important. So good death, according to me, is allowing the patient, especially when we do not see any possibility of getting back of his self-sustenance, is just to allow them to have their end, not by disconnecting all the support, but the vital supports should be maintained. And more than that, the family should be supported by the treating team. When that is not done, then it becomes a complaint. Most of the complaints against the nurse against hospital is we are not talking to them, we are not disclosing openly, we are not getting their views on the patient's care. In most of the times, we take the decision, we take the justification, we force the attenders or the family members to accept what is to be done, goes on and on. So, about 2 months ago, patients was admitted elsewhere with a massive cerebral hemorrhage. The doctors went on treating initially medical management and surgery, then second surgery, then third surgery. There are more than 10 MRIs. And finally, after 1.5 months, the patient was just like that left alone. So the family lost all their properties, all their resources, and finally they cursed the utilitarians and took the dead body. So this is the problem in most of the situations. Even right now, I was not able to attend completely because one of my patients waiting outside because of my commitment to the meeting, he just collapsed. So I had to go and attend and immediately take him. All these things I was doing it as I was listening to the meeting. Now the patient is not stable, so I come back to attend to the meeting again. So allowing in most of the situations when there is no possibility of returning to life, at least a near normal life, a self-sustenance life. When that is not possible, you educate, you make the family to accept what is the reality. When that reality is not properly deliberated with the family, then there is a problem always that we have to face even after the patient is. As a doctor, as a hospital. So it is a high time, as Professor Ganapathi has told, that the time has come where there is a neuropsychology, neurophysiology care. And Professor Tambaya used to tell this, tender loving care. So in most of this, say a patient with any organ failure for that matter, let it be neural failure or a cardiac failure or respiratory failure or any system failure, major vital organ failure. What we give it of life. Whatever the procedure treatment that we give, it should result in a better quality so that whatever days of life, that should be some good quality. We cannot allow the patient to be supported in all possible angles and allowing the patient to die after developing bed sores and average life and wasting and totally depending upon some parental nutrition. So this are some of the issues the university should include the care and taking care of the dying patients. Probably what we are doing now. So thanks for this opportunity.
Thank you, sir. Thank you. Though there had been some connectivity
Yes,
issues, I
madam.
think the points made by Professor Rajendran are very clear.
Hello?
The patient should be permitted to decide at a point of time where self-sustenance
Yes.
becomes a question. And an extremely important factor that Professor C.R. has touched upon, taking the family into consideration and kind of having a discussion with them, educating the family, and probably including the family in the decision making. Your points well taken, sir. Thank you very much for joining us in spite of an emergency there in the hospital. And we wish your patient who waited outside a speedy recovery. All of us pray for his recovery. And may I now request Professor Subhash here to offer his remarks.
Hello?
This lecture highlights what is very old. Think about being because need to understand things better, about the things are well understood. And point number two, if I hold it right, I will inseparable. Is standing on and on with times and colors. Point number three, definition. I will not take a class on that. Just to say, it is like the beauty shines in the eyes of the people. Cardiologist will define in long way. Okay. Somebody comes on the roadside will define his own way. End of the day, death is death. Everyone becomes dead. Important. Correct diagnosis, documentation is very, very important. Not only Ganapathi. These are Greek god of death, and the Greeks have got one of the things. What is important is sort of information that in one university, there is a PhD degree for Ganapathi. see the patient A to Z on death, not necessarily point of death, even before death, the time of death, their approaches are far wide. There is a accepted postgraduate course, thanatology, one of the universities. Point number 5. Before we talk on good death and death, I would like to put forward a simple concept. Things here. Process of dying. It is a process of dying that makes it good, bad, something painful, blah, blah, whatever it is. Message I want to convey. Death by itself, death processes. You can modify all the processes, tell the family about the processes, then as a patient in the family, the standard question is, as a physician, you can tell that it's all bad, don't go to normal, not point the exact time. Something superhuman, above us, fact and everything. Had performance. Why we can't fix it? That is the beauty of it. And I rightly brought in about ironics of preservation. Centers the world, I mean USA, but 1,500 people have been trained on cryopreservation. So you wonder what is going to happen. Things are already proved. They're able to prevent all changes, all decompositions, all cellular, subcellular activities are controlled by cryopreservation. Second concept, technology should be the one day, nerve starts functioning, we can come back. The basic principle. How many you will say people are making advance booking of cryopreservation and diagnostics? Exactly, all the things are written in my book. It's a very, very big subject. And if you have more sections on this, have a categorized approach, call people to just a process. Giving us website view. Like to go, yeah. There's the possibilities of introducing thanatology. Thank you.
Thank you, sir. Thank you for throwing light on several things which are happening across the globe. Thank you very much. And here I find in the chat box a kind of a suggestion which has come from Dr. Suresh Beam Singh. Yes, there should have been more discussion on aging gene and longevity. Dr. Suresh, we take your point, and sometime in the near future, we shall have some discussion on the aging gene and the genomics related to longevity, death, and all such things. If there are no further opinions coming from any of the people in the audience, I would like to announce about the topic for the next edition of the webinar. I think we've discussed enough about death for the day, for the session. I don't say everything about death has been discussed, as rightly said by Dr. Subhash. Death is something related to life. If I could say, life and death are the two sides of the same coin. So as long as life survives, death will also survive. So everything under the sun will have to one day perish. Again, I'm reminded of the lines from Kannadasan, Maranathai enni kalangidum Vijaya, நீ அழிக்காவிட்டாலும் இவர்களின் மேனி அழிந்துதான் தீரும் மரணத்தின் வண்ணம் சொல்கிறேன் கேள். So there is one day where everything will disappear. Everything will disappear, including the Panchabhutas, is what philosophy tells us. So if there are any opinions, sir, before I give it to you, let me check if there are anyone, anyone in the audience who would want to say anything, any opinions, any questions. Welcome. Yes, Dr. Subhash wants to say something. Yes, sir.
I told other people happening, has happened. Whatever is going to happen is also for good. So I'm saying all the three goals that we apply. This means positive one, and that is what I'm highlighting in that book.
Thank you, sir. I don't think so any other opinion or remark is coming forth. So with that positive note on something which is generally perceived to be negative. That is why in the opening remark I said people had been raising their eyebrows saying, what is good death? Can there be a good death? Death is something not bad, is the basic concept that I think everyone will have to accept, especially people who belong to the medical fraternity. Death is not something which is bad. Death is part of life and death cannot be avoided. It's something inevitable, but then there should always be a positive approach to handle death the right way, face death the right way. If there are no further remarks coming forth, Dr. Ranjit, anything that you would want to say? Dr. Ravindra Mohan?
No, madam.
Yeah, actually, there's something which comes to my mind. Well,
Yes, Ranjit.
we talked about, like the various things which we could face in the event of a death, how to face the death and everything. So how do we assist in helping people understand an event called a sudden, unexpected, unexplained death?
Yes. Professor Avius, would you want to take that? The question is that how do we make people understand an unexpected death? Something that happens suddenly. You can talk from here, sir. You can talk from here.
It is not the grief alone, sir. Sir, it's actually like, how do we, like, well, we are at a fix. We don't know how to handle such a situation because we don't really have a guideline to follow. And it can happen at various levels, various things, including death on table. Can't hear you, sir. Ravindran, sir, we cannot hear you.
We can give them this particular point stated if a person has crossed years, it has been well documented. Every year is a bonus. When he crosses 60, every month is a bonus. When he crosses 70, every week is a bonus. When he crosses 80, every day is a bonus. Crosses 90 to 186. No, we do not know still how the heart rate functions, how the spontaneous rhythm of the sinus note.
Sir, we cannot hear you, sir.
Sir, I beg to differ with you, sir. Professor Avius, sir, I am sitting next to you, very next to you. All this philosophy is nice to hear and nice to talk. In fact, tell me the music of philosophy. I would vouch for it much more than any one of you. But then, how do we tell this to the family? This cannot be the sermon that someone can tell the family when the healthcare worker is faced with a sudden death in a hospital or in the setup he is in. So how do we handle the situation is what probably Ranjit is wanting to say. Yes, Ranjit?
Yes, exactly. That's what I'm saying. Well, the death is, well, it's a smooth, comfortable thing for the patient to go through. But, how do we, how the parent and the family has to take it, and how do we move on from there? How do we get, how do we manage the situation?
The scientist want to look at the emotion.
Sir, we cannot hear you, sir. I think something is not right with your microphone.
When there is a sudden death, and you're going to approach the patient.
Sir, we cannot hear you, sir.
Yeah, sorry. At some point of time, you cannot estimate the emotion, how much
Sorry, your microphone is muted, I guess. Maybe you can just.
Sorry.
Ranjit, can you hear me?
I can hear you very well.
Then he's sitting very next to me, so it cannot be. It is the same microphone. Yes.
I can just hear a distant muffle. That's all. No. Sorry, I cannot hear anything.
Emotions are always there, reactions are always there for any person. But death is a tragedy. But tragedy should be the final answer. Ultimately,
Ranjit, I would consolidate on what Dr. Subhash is trying to tell you now as a response to your question. Dr. Subhash says practicality will have to take over, and the doctor cannot be carried away by the emotions which are prevalent at that point of time. But then I personally feel I'm not talking here as a VC or as someone who belongs to the medical fraternity, but I think as a member of the society, I personally feel emotions cannot be avoided at that point of time. Some of us might say, yes, control emotions. There could be a few of us who could control emotions, but for many of the human beings, it may not be possible to control emotions at that point of time, especially when the death is going to be very sudden, and the healthcare worker probably will have to face the brunt of all the attack that goes on at that point of time. Now, permit me to quote personally here. I'm sorry to be treading into the personal zone, but then permit me, because the discussion has come to that level. Dr. Ranjit and I were classmates. So Ranjit knows to some extent, my mother was a doctor. My father was a doctor. Despite all this, when my father passed away, my mother for a few months would squarely turn back and say, I was the one who killed my father. Now I had to accept that emotion. I'm telling this not to blame anyone, but then trying to tell there are situations where emotions become uncontrollable. And as healthcare personnel, we would have to learn to deal with those emotions, not just say emotions will have to be put away. I don't think so. We'll be right in telling the patient's family, put away your emotions, but then we probably will have to give them the kind of comfort so that the emotions fade away slowly and gradually.
Well said. Actually, that's true. That's true. The compassion part, well,
So
I mean, we cannot go to react, but the thing is,
you're not
emotion will play.
Emotions will be there, Ranjit, and I think each one will have to learn in the field to deal with the kind of emotion, maybe give them a little comfort. And I would even go to the extent of saying sometimes the healthcare personnel will have to understand and bear the brunt also. There could be some kind of, some mudslinging or some kind of talk, bad mouthing, but then probably we will have to understand that it is a psychological emotion and it's a kind of an exacerbation that happens. There could be ups and downs, but I think each one of us will have to practically deal with it in the field, on the ground. It's a ground reality.
That's true, very true.
Yes, sir. Yes, sir. Your point taken well. Yes, that
That is why becoming is conscious, being is unconscious. This is the greatest person. Why I am saying this is the sudden spurt of the emotion due to the sudden death of any person. As Madam rightly pointed out, in some person you are taught how to not express emotion. That is one of the British system where the schooling system itself teaches it. In India, we are exactly the opposite. The emotions are allowed to spring right from your childhood days. So myself and V.S. Ramachandran try to quantify the emotions in a way which we felt very miserably, because it operates at the awareness level. Why I am bringing that to the notice is the science of death is different from, as you rightly pointed out, the process of death and then the science of death. Science of death can never become a scientific fact because the error of the other way of proving it is going to be very tough in death. That is going to be the, he rightly pointed out, death is not a disease. I agree with it, but what does it cause it? Disease can cause it, disorders can cause it, the mind can cause it, the entire process can cause the death. That is why our ancient people dying in end is bad. Dying due to all accidents, that is actually not a, that's also a bad death. Unnatural death called bad death. Whereas the good death, it is something which doctors, healthcare workers, patients' family should mingle together. Give the 10 page notes which are given to the madam, so that is going to be the basis on which the good death can be beautifully demystified by just talk, because ultimately the comfort is.
Thank you, sir. I think we've had enough and more discussion on death, and again, ending it on a very positive note from the interaction that we've had with Dr. Ranjit, Dr. Subhash, Dr. A.V. Srinivasan, Professor C. Rajendran, and of course, a wonderful lecture from Dr. K. Ganapathi. We are drawing to a close of this edition of the webinar. As regular, we would meet again on the 17th, the third Friday of a month is our webinar day. So on the 17th of September at 2 p.m. IST, we meet again for yet another interesting edition, SARS-CoV-2 in pregnant women. The topic would be SARS-CoV-2 in pregnant women, and the speaker for the day would be Dr. Vijay Kumar Velu from the M.G.R Vaccine Center, CDC, Atlanta. Dr. Velu would join from Atlanta. He is with the M.G.R Vaccine Center, and inviting all of you to join us on the 17th of September to discuss on the topic SARS-CoV-2 in pregnant women at 2 p.m. Indian Standard Time. Thanking you very much today. Thanks, Professor Ganapathi. Thanks, Dr. Subhash, Dr. A.V. Srinivasan, Dr. C. Rajendran, Dr. Ranjit, Dr. Ravindra Mohan, Dr. Sabarat Navel, Dr. Suresh Bhim Singh, and everyone, each one, signing off from the university. Thank you very much.
So thank you again. It was a
Thank you,
wonderful-
madam. Thank you very much for arranging this webinar.
Thank you.